So we'll call the insurance meeting to order. Michael, do you want to talk about the Acciani retirements?
Sure. So I submitted the agenda. I just want to remind everybody, this is Meg Kelsey. She's our representative from Marshall and Sterling Insurance. Traditionally, I know a lot of you were familiar with Steve Acciani representing the county. And when Steve transitioned from his business over to Marshall and Sterling, he was there and then decided that he was ready to call it, golf, whatever he's going to start doing. He was going to, he and Betsy, decided at that point they were going to be retiring. So we've received official notification from Marshall and Sterling. Again, this is our first meeting since that. So I just wanted to supply you all with a copy of that letter. Good morning, good afternoon, whatever day it is. So, so just so you all have formal notification of that. Okay. So second on the agenda is the prescription RX coverage that is for self-funded groups from CDPHP. Now, this is a program that certainly Meg, Lori, please jump in at any time, but we had a wonderful presentation. Meg, myself, and Lori met the individuals from CDPHP, as well as a pharmacist from the company who performs this service with CDPHP. This is something that they're giving us the opportunity to elect to join if we choose to do so. So I'll just kind of go through what paperwork is here, explain the program very, very quickly. And if you need additional information, we can get it. They have offered to certainly come and do a presentation for you. I don't necessarily think that's necessary, but that's certainly up to you, whatever you guys think that you want to do. So in a nutshell, what this is this is a group of pharmacists that work directly with CDPHP to attempt to kind of like step therapy and kind of, as far as what prescription drugs an employee is taking, if they haven't tried something else that could possibly be lower cost, or that an employee could potentially take. These pharmacists reach out directly to the medical providers. No more trying to put it on the employees where the employee doesn't know. They can't answer necessarily questions about their health conditions, their prescriptions. Most of the times when an employee is talking about a prescription, it's because they've just seen the commercial on television while they were watching a movie or something, and it happened to be
So there's not a difference between a brand and a generic, a different medication altogether.
Potentially, but it could be a difference between same medication for some sort of prescription need that they just happen to put them on a name brand, or they happen to put them on a certain name brand where another name brand may be qualifying for a discount program where they could get it less expensive. Okay. But what has always been the issue for us is the fact that, as I mentioned, when employees are spoken to about this it's not their expertise. They may know their health, but they don't know the best way to prescribe it, myself included. I don't know anybody who is able to do that. So what we loved about this presentation is the fact that the behind the scenes conversation happens from medical provider to medical provider. It's the pharmacists that work with here having conversations directly with the employees' physicians. And if the physician is able to say, listen, I'm sorry, but this is not something that we're able to do because of whatever, okay, then it's not something that they're able to do. But they're working with the doctor to be able to look at alternatives and potentially lower cost prescriptions.
Is it only with the preferred pharmacies, or is it any pharmacy?
This has nothing to do with that.
Okay.
This is a completely separate service that these pharmacists that aren't even going to be seen. Our employees.
CDPHP
Thank you.
pharmacy.
Exactly.
They're a pharmacist.
Right.
So what triggers them to do that?
High cost notifications, drugs that are expensive.
Then they
Potentially.
automatically start
Yep.
reaching out?
Yep, they review.
So who was that benefiting? The county more than the employee, right?
Well, it's going to review, it's both, because the immediate part will be lower cost to the county. But remember, premium equivalents for every single employee are set on an annual basis because of last year's claims.
Okay.
So if we're able to drive costs down, then we're looking at potentially a different way to adjust our premium equivalents for the next year.
Okay.
And it could be a lower tier drug too.
Yeah,
Exactly,
exactly.
right, thank you, right, which could be a less of a copay, thank you, that's
Yes.
excellent, yeah. I
Because they
forgot
did
about that.
describe it too, as the doctor goes on and says, okay, this person has diabetes and I want to put them on this drug, I want to put them on some kind of medication, and it just automatically populates up like, okay, the first medication, they choose that one and just go with it. They don't necessarily go through the
But I
list
think
of all
the
the
most important
medications.
part of what I was asking is that
if someone just said, well, as an employee here, well, how does it tell? What do I care? Well, you
Right.
just said it, drive plus.
Exactly, yeah.
But that's important.
Right, it could
Yeah.
potentially reduce premium equivalence going forward for
Right.
the years in the future. Okay, so if you go to the last page, you can see this was kind of the $103,000 that they have put in here. This was the number that they came to us and said, this could potentially be your savings.
Yeah, this.
It doesn't have it. I'm sorry, everything was scanned. Well, I apologize. The last page of it was potentially, it's the pharmacy concierge program savings analysis. And from that, they did based on our current usage over the last year, what they thought that we could have saved if our medications were staying the same going forward. Now, again, this is no different than when we get an RFP. Remember, they're saying the what ifs. This would be if every doctor
Right.
looked at every one of these medications
Not
and
gonna
got exactly, but a maximum savings at that point of over $100,000. But I will tell you one of the reasons why I just think that this is a win-win all around. And it's the fact that we potentially would be getting charged, the PMPM is $1.75, so per member per month, okay? So looking at 1,229 members at $1.75 PMPM, we were looking at an annual cost of $25,809. All right, so let's say that was going to be for this year. We are guaranteed, if our rebates or if our savings, I don't want to say rebates, I'm sorry. If our savings is not $25,809, that's what they're going to pay us back. They will pay us back at least our admin fee.
Right.
At least what we're paying. So no matter what, anything we are fronting at the PMPM, and I can't imagine all of a sudden, unless we're going to start expanding our departments and acquiring new departments, that we're going to rush, up from 1,229 members, at the 175.
So we get a free ride for the first year.
It's every year.
Every
year. It's every year.
But do we renew? I thought you said for the first year, we get $25,000 for the first year.
No.
It's every year.
Yeah, yes, the 25,000 is just because that's taking the number of members that we have.
Currently.
And exactly. And she was saying that as a part of this, they guarantee that they will match our PMPM every year. That is the least that will be.
Right, if we save it, they won't.
Yeah.
Exactly, right? So if
We say.
Right, yeah.
if we save 13,000, we're gonna get 25 grand.
26,000, we don't get the 25 back.
Correct.
We get 26. If we save 26. we get
Whatever you save,
26.
you get above
You're
the
getting-
If we
25.
save
Above
100,
the 25.
Yeah.
anything we save
Yeah.
above, we get it. But if we only save 13,000, they're gonna give us the 25.
Yep, gotcha.
And that's why all of us were just kind of like, okay, so
That's why
Where-
it's a free ride.
Is
Where
this
you
a
getting-
cost- is there a
where you
cost to
getting-
enroll?
where you're getting that's right. Where you're getting the 1-for-1 ROI. Like, I wish everything was that's that. No risk.
So let me ask this question. If I'm taking drug A, which is $100, and
Yeah.
they say you can take drug B, which is $10,
Mhm.
I, as the member, has to take the B?
Your doctor is
We're
going to have the
prescribed.
conversation with you that to prescribe the B, because you're going to have to go. back
Right,
with
so
your
I can say to the
get
doctor,
the
no
B.
way, whatever. It's according to what I work out with my doctor. to say,
Exactly.
okay. It's not like you're forcing. them.
No, there's no forcing ability here.
So when I leave the doctor's office, I leave with a script, or they've called a script in. So in the time between my travel from the doctor's office to the pharmacist, the pharmacy gets the script, they look at it and they say, oh, they called the doctor?
It's happened at the doctor's level.
It
It's
happens
never, yeah,
before you leave the office.
yes. The pharmacist from CDPHP is gonna call your provider before you go, when you're at the medical provider, and have that conversation with them, anticipating that you could potentially go on a different drug. So you would have that script to go to the pharmacy with. It wouldn't happen at the pharmacy level. That would be at your provider level prescribing you that specific new drug if you felt that you wanted to
Wouldn't that
take it.
slow the process
I
down?
was thinking, yeah.
No, I
absolutely.
don't think necessarily, because at that point, they're gonna do an outreach based on so currently they're gonna look at what everybody's taking today. So it could potentially with a new prescription might bump up a little bit, but all of the people who are currently on prescriptions today, they're gonna look at that file, see what the opportunities are there, start those outreach and begin that outreach.
So we're gonna have an alignment. If we were to go on this plan, the pharmacist would look at the prescription. So if I went in to renew, I might be advised at that point in time. I didn't even see the doctor.
It wouldn't just be new medication.
Just
It
new
would be-
medication.
No, it wouldn't just be new. It
Not
would be
just new.
existing medication
Right.
also. They're gonna review this and take a look to see whether or not, I think what Supervisor Adams is asking is, so you go into your doctor and the doctor says to you, I'm sorry, but your A1C is this, we're gonna put you on, I don't know, metformin or something like that. And then at that point, is the doctor gonna write the prescription and hand it to the employer? They don't even hand it anymore. They zip it off to
They just
Walgreens.
call the pharmacy.
Exactly, right. So are they involved at that point? Is CDPHP
I don't
involved?
know.
And
They
it's
won't
no,
say
it's
it's
a,
like-
it's
it's
a
the
look
look.
back. Exactly. So you're gonna get your prescription for metformin.
Yeah.
Okay, using that example. And then you're going to leave. And then they're going to review our entire as a whole. All right, all of our cases, any of the prescriptions that stick out. And then they're gonna call your physician and they're gonna say, okay, we see here, and maybe metformin's not a good example, but I'm trying to think of
Doesn't
whether it's like,
matter.
okay,
Yeah.
they're gonna say, listen, we see here that you have such and such who was just recently diagnosed with this. Is there a reason that you didn't try them out on blank? Is there a reason that they couldn't have done this? And, and they're that conversation, not with an employee who doesn't have the
No,
expertise.
no, I understand all
Yeah,
that.
which is why we loved it.
But I'm thinking about, I just had my physical and
Okay.
the nurse comes in and said, you have 10 minutes for a physical, it's 11 minutes, you need to go.
Oh,
So if somebody, I don't know, if somebody, no, and so they have all these boundaries now in
Sure.
terms of how much time they can spend with people. How are they gonna take these calls and have these conversations about these drugs?
Sure.
That's what I'm thinking,
yeah.
on the practical side. I mean,
Yes.
in theory, it all sounds great, but how does that get done?
Well, I mean, this is for the pharmacists to be doing this. This is for CDPHP and their company to taking part in this as well. So, my attitude would be that I would be concerned about that if we weren't going to get our ROI. If we weren't going to get one for
Okay.
one and we had to worry about them saying, listen, you've got to get this many calls in order for you to get your money. And if that's not the case, then that's not on us, that's on them. And then if we don't feel that there's enough, we're gonna get reports on how many contacts are made and how many services have been done and how many improvements. But if their lack of ability to be able to speak with the providers is going to cut down then on the lack of savings. So if we find that the savings is really not that, we're not gonna renew the contract.
So
and
we
we're going
need
to
to wait
go
and see.
further.
We try it a year and see how.
That's,
Right.
So what happens if you don't renew? Just stay it the way it is? I mean, if you don't go with this program?
if we don't go with it, it just stays this way. It's just they're coming to us from CDPHP as
So
our
they can just
PBM.
save money too.
Well, potentially, but
It's a money
not,
save. The
though.
whole thing is a
We
money
pay-
save.
Right.
I just don't want it to feel like that for our employees is what I guess I'm driving at.
yeah,
Like they're gonna put me on something else just because it's saving X and I realize we all do that with generic drugs, but it feels to me like, because I know how, drug reps work and what pills they're pushing versus these
right, which
pills.
is a
and
whole
They're
other
whining
part
and
of this.
dining
We're
doctors.
not
I know all
looking,
about
we're
that. I
not
used to
looking at
cater to
pharmacy
them.
kickbacks as a part of
Right.
this conversation
Right.
either. You could have a doctor putting you on something mainly on the fact that the poster's hanging on the wall. Like, I don't know.
There's no
and
doubt about that.
Their umbrella and beach
Right. I'm
umbrella at their
just
house.
saying
is
that
the
you're
same
rolling
thing.
it out to a lot of employees. I
Yeah.
don't want it to feel that way for them is what I'm saying. It
So
makes sense
this-
to me to try it.
This is nothing that is even, it is not even apparent to anyone. It's apparent to us that we're signing on for it and we're looking for the
Well, it's
same.
gonna be
it's apparent
apparent
to
because
the
they're gonna
patient.
switch their drugs.
Well, if the doctor.
Not
calls the
necessarily.
patient, Have that, but you're saying the doctor calls the patient, to
Right,
have a conversation.
that is their
The doctor may
conversation.
say, I'd like to move you from A to B.
fine.
He may never introduce the idea of cost. He just would like to say, I'd like to move you from A to B, and that's how it, I don't think he's obligated to mention that it's.
No,
cost
and nor
related.
is the,
He wouldn't,
nor
no.
is the patient/employee obligated to change their medication.
Right.
Like, there's no bullying on them to say, because they've offered to do it, no physician is going to say, you have to take this. There's always that open
Well,
dialogue.
that happens sometimes when you go to pick up a drug and they
Yeah.
switch it, right? I mean, like,
In
it's,
front of
that's
Oh, yeah.
Well, generics come out. all
what I'm
the
saying. It
time.
happens all the time. They
And
got
they're
taking a
patents
different
for
one.
5 years. and
No,
then
it's the same. I'm like, oh, okay.
I think the conversation taking place at the professional level is a plus.
Right.
And then, because while you or others may be aware of what they're taking, many more people are not aware of
Sure.
what they're taking. They just take what the doctor takes.
And again, if you would like further information, Megan certainly offered, we can get the group in here to talk with you. I mean, it was like a 10-minute conversation, 15-minute conversation that we had with them. It wasn't, all the information that they presented was in this packet.
In order to get to maximize the return. Is there some alignment that takes place? Let's say we were to sign this today and the plan takes effect tomorrow. Would they then go through all 1,200 employees' drug files and then have those so there's a baseline alignment that will take place
So they've kind of already gone through what has happened in the
in order
past.
to do the
In order
estimate?
to do the estimate,
Right.
that's where you get
Right, so
the,
they already know there's a huge.
they already know there's that
It's all-
potential.
That's why they
It's-
offer the 25,000.
It's our PBM. It's our PBM. It's their
Okay.
pharmacist. So it's like they've already known.
Okay.
But it's just, they can't make that call to the employee's provider without our approval that we're approving for them to be able to do those
Is there
things.
any downside to having that call made?
I don't particularly see one. CDPHP obviously is putting, the money on the line because they do their entire book of business. So they've had this program in place. So for them, they look at all of their clients and see what the potential is in savings. The downfall to me would be nothing because the employee's not really going to know. And they have the opportunity to say, no, I don't want to take that generic drug. But I
From the
think coming,
pharmacist. Yeah, from their
from their
physician.
their physician, I think eliminating that piece where you potentially want an employee to go look, see if I can find a cheaper drug. Do I go to a different pharmacy? That's all taken off the table. This is just a conversation between them and their provider, with the provider speaking to a pharmacist to see if it even, makes sense for that employee to make that change. So I don't see any disruption to your employees.
But would the pharmacist have a different opinion than the doctor who prescribed the medicine?
No, because the pharmacist is just gonna get that prescription then from that provider.
So there would be the check-in between the pharmacist and the provider.
Correct.
Because the prescription has to be modified.
Yes.
And are the providers,
That's the question.
receptive to this program? I'm the doctor and I'm putting you on A, and then CDPHP calls me and says, hey, we think you could put you on B. Are doctors have been receptive to that?
They
And
said
they're-
they were because they said
they're
when they go in their
responsive and
system,
they're-
it just brings up the first drug and they just pick that first drug. They aren't thinking about, you
rest
have
of it.
diabetes, okay, it says start with metformin, check, done. And that's what they do. Instead of researching and saying, oh, well, if we put them on XYZ drug,
Well, I think
You could
that's
say
somewhat
very-
true. When I was a cancer patient, had post-chemo drugs, and the oncologist said, when you go to the pharmacy, do not substitute these drugs. I want you to have.
There you
these
go.
drugs."
yeah,
So-
right. And
So
you
I
will
do
have
think
doctors
there
that
is
will
some
say that too.
participation.
There are
So there would be
some,
no discussion at that point because
Okay.
the physician has made the decision that this is exactly
Right.
based on their medical analysis.
Yep.
So,
Right.
so thank you. That's a great example.
Mhm.
Thank you.
And
But-
another example is when you have multiple prescriptions from different providers. In my experience, it's often the pharmacist that sees that interaction between all of those prescriptions that the individual doctors that are writing those
Oh,
prescriptions
right.
don't see.
Right.
So sometimes the pharmacists have an insight that the doctors don't have because they don't know all the other meds you're taking.
Which is why they try to push you to one pharmacy from multiple physicians based on specialty positions, because your cardiologist doesn't always necessarily know.
Right.
They always try to say there's centralized healthcare databases that they do, but it doesn't always necessarily happen.
But CDPHP, that pharmacist would have all of the medications that you are
Exactly,
currently
from all
taking.
the
from
physicians,
all of the
right,
physicians.
right.
Yeah,
they
because
would know.
when you go to the doctor, they ask you, what do you want? Are you on any new medications? And
Right.
a lot of people don't even know what they're on.
Right.
Right. And that's why I think it's so important what you just said. I'm sorry.
By pushing a generic drug, does that have any bottom line, issues with the pharmacy itself
No one's pushing any generic drugs. This doesn't have anything.
or an
to do-
alternative?
Does it, so does it have what? I'm sorry, underlying
I'm
what?
saying,
Does
that
it have
is
a
the
treatment
pharmacy,
effect?
would the pharmacy itself be receptive to doing that?
The pharmacy just fills the drug. The pharmacy just fills whatever the order is from the doctor.
Well, okay, let's say the doctor is gonna use an alternative drug because it's less expensive.
Yeah.
Mhm.
Does that have any bottom line problem with the pharmacy itself, or,
No, because the pharmacy is where the pharmacist is. It's all CDPHP.
okay?
Yeah.
Oh, it comes out of I'm sorry.
Well, the pharmacist is coming from CDPHP and they're filling it at a CDPHP, at a regular pharmacy.
Oh,
Like you're
yeah.
doing it at a,
Approved
right,
pharmacy,
exactly.
I wasn't.
Yeah. Oh, no, it's fine.
Wasn't Walgreens itself, or it was a,
No.
Oh, yeah, no, the CDPHP pharmacist will reach out to a provider,
I see.
and that provider sends it to whatever pharmacy that.
Right, so the
you-
pharmacy is really not even that involved.
No.
It's
okay, that answers
Right.
that.
It's
Yeah,
this
the
person
pharmacists are
to the
from-
doctor.
Yeah.
Correct.
It's not the pharmacist actually filling the drug at the retail pharmacy.
I see.
Yeah. Thank you. I'm sorry if I wasn't clear.
Right, so if that person doesn't get a hold of the provider for whatever
They're gonna
reason,
fill their
a day
regular
or two,
medication.
they're
Yeah,
gonna just fill.
right. Because they wouldn't have a revised script
Right.
to send.
Sometimes,
to
we
send
try
the
to get a
pharmacy.
script filled and it takes 3 days.
Right.
Because something.
Right.
Okay.
So that's how they, because it's not the pharmacist that's filling the script, that's how they know to make the phone call, because it's not happening on site, it's happening outside of site in a different review.
Right. Pharmacists are reviewing it internally from their claims.
Okay.
I think financially, it's a no-brainer. I understand the other concerns, though. I'd be interested to find out how successful these CDPHP pharmacists are in getting back to the provider and the provider responding.
Mhm.
I mean, we all know you can't get a provider to
Right.
respond. You're lucky to get an
That's what-
appointment.
Yeah.
And
And
I
it- and
think
it's
that
a-
probably rate is maybe 50% or less. maybe.
Right. And it's impossible for us to know that.
Yeah.
You know what I'm saying?
Right.
Like I don't think they can just give us a number, because where would that number come from? You'd have to have like, okay, so it's the scope of 10 people and then they guinea pig that, like, I don't know.
Right, that's why
what
that
numbers they would use.
$100,000 number is
Right.
very unrealistic.
And we use that as, what
No, but the
was
25,
exactly our
that's our
statement.
baseline.
We said to them, okay, that's like saying back during the PBM presentations that you're gonna save all this money in international pharmacists. It doesn't necessarily mean that everyone we couldn't push everyone to go to an international pharmacy. So when they were telling us, we'll save you 170 grand, that sounds wonderful, but it doesn't necessarily mean they'll get that max.
Right.
So if it is gonna cost us, let's just say back to the 25 number, but we are guaranteed to get the 25 number.
Mhm.
If we find that that's all we're getting, we're no worse ahead. We're making the same money. We're getting back the same money that we spent. So it's no expense for the county. But as you said, we
The
want
worst
to.
case scenario is we save 25 grand.
Exactly. Well, whatever they end up charging us.
So this is all on forecast numbers. Are there any examples of this plan having been implemented in prior periods and what those results have been, how they've compared to forecast?
If you would like some sort of studies for us to bring back, we can
I'm just
certainly go
asking
back
if
to
they
them.
exist. I'm
Oh,
trying to figure out if
I'm
you're on
not
the
sure. We
bleeding edge
certainly
of
can answer
education
that.
or somebody's done it before.
Yeah.
Yeah, I don't have specific examples from groups, but they could definitely provide that. They did give us examples, and I think they talked about 30%, 40%, possibly. I can't remember off the top
Was
of
the
my head.
minimum standard.
Yeah, like around
30% of the 100 grand, basically.
30 or 40%. Yeah,
Which would
like
make
minimum,
sense if they're
which
gonna
makes
offer
sense.
25%.
Right, they're gonna
Which is
cover
what
their-
number you're talking
They're
about. Yeah.
basically, they figured they can cover that, is what they're saying.
Yeah, so, but again, I can ask if they can potentially give us a group in same kind of range and just see what they historically have. Oh, no, not at all.
No, not at all. And back to what we were talking about, future versus past, it is literally about things that have already been being done and being able to do that forward, because it is referred to as a retrospective cost containment. So they're using retrospective information in order to potentially forecast going forward how we can better save money on those expenses. Okay, so do you want to table this month and then,
I don't need to
and we'll
table
be
it.
able to provide that information, or what we would have to do is we're just asking for a recommendation for us to be able to go to the Board of Supervisors during a traditional Board of Supervisors meeting to ask
I'll
them
make
to
that
allow us to
motion.
contract with
That
this.
we go with the reduced pharmacy cost guaranteed
Okay.
program.
I'll
Thank you,
second it.
thank you. And we can
All
certainly.
in favor? Aye. Opposed? Carried.
Okay, wonderful. Thank you. You were all supplied, now certainly just a real 5-second version on how county retiree health insurance is done. When our employees are fortunate enough to be able to retire and they are on our health insurance program, or if they want to come back later under an open enrollment period, we have county retiree health insurance. And certainly, you know, we used to have a large number of Medicare Advantage plans. We now have only Anthem. We have a commercial plan from when people are at retirement on or around the age of 55 up until they're 64 and 11 months, and then they're ready to turn 65 and start going on to Medicare and our Medicare Advantage. What we have seen as a continuous issue that we felt that we wanted to get ahead of is the fact that ensuring that there is a policy in effect so that when people retire, there is a clear understanding, but also a clear outline for how county health insurance is, what you have to do in order to be eligible, but what you also have to do in order to continue payment for. It becomes an issue when individuals who don't pay for their health insurance, and then we are chasing after them on a regular basis. And we have talked in the past about whether or not we could put some sort of rule in place. And as a rule, this committee may not all be the same members, but the committee at that point voted if they haven't paid for their health insurance in 3 months, they're canceled. So after conversations with the county attorney's office, he said, that's great, but you want that to be a formal policy. Because you are talking about medical conditions, you're talking about prescription coverage, you're talking about potential pre-existing conditions, all this kind of wonderful stuff. We want to make sure that our employees and our retirees are versed and understand what the possible outcome could be if they're not paying their insurance in a timely manner. Okay, so that was the point of this, was to explain who's eligible, why they're eligible, how they enroll, what the cost could be based on, and some of these categories are going to be based on what collective bargaining agreement they came from. So we're not going to be able to put the exact description in here because, you know, some of them are, if you've been here for this many years, it's this much. Some of them are something different. Some people, you know, have to retire after 30 and 55. If you're a police officer, you're fortunate enough to be able to retire at 20. Medicare coordination, how their sick bank is computed. And then we, as discussed, about in reference to insufficient funds. That is something unfortunately poor PJ's office has to deal with.
So what is the normal for somebody that has health insurance? I mean, I know what it's like, car insurance and homeowners, but if you don't pay, your insurance is due the end of, what do you mean, April? It's due April 1st. You don't pay it in April, March 1st comes around, what happens?
So your insurance is due the first of the month.
Right.
So you should be paying April, should be being paid in May. Being paid March, pardon me, sorry,
Okay.
wrong month. So this outlines on the last page about when the letters come out on the 10th of the month and then when that goes.
The
So it's-
10th of the same month?
Yes, because you're overdue with that.
So I just want to make sure I understand, you're paying in advance of, you're paying a month in advance.
You're paying by the first for the first. You're paying for your
Okay, so
coverage, right?
By the
that-
first for the following first, so you're paying March 1st for April 1st.
No, you pay March 1st, March 1st.
Okay.
Okay, so that's my question. So
Yep.
April 1st, it's
Yep.
due, you don't pay it. What
Yep.
happens?
So then you're gonna get notification on, let's say you used April 1st, on May 1st. And a letter is going to, yeah, I'll let you go. You go ahead.
So if it's not paid on April 1st, I send a letter on April 10th.
Yes.
Then you didn't pay, don't forget, we have to pay. But if it's not paid again on May 1st, so then you owe for April and May, we send another letter on May 10th saying, we're terminating you June 1st
Mhm.
if you don't pay for your April, May premiums.
Right.
And then June 1st.
And we're paying that.
Does this,
So why are we going so far with it? I know that's the
Medicare-
policy. but
Medicare
like-
rules. Right.
Okay, so that's my question.
Yes.
Are we obligated to do that 2 months?
For Medicare, we are, not for the
Medicare
CDPHP, but for Medicare, we are.
So what's the policy for CDPHP?
We're doing the same policy for all
Right.
insurance.
2 months.
Mhm.
And that's, you said that's the rule, not on CDPHP, it's not.
And we did the Medicare.
And we did put in here historically, you know, people call up and say, my gosh, this has happened economically. I'm unable to do such and such. Can I do a payment period? We've even outlined in here how often they can do that.
And how many of these do we have? I don't want exact numbers, but.
enough?
A couple.
It's more about managing risk though, because we don't want to cancel somebody and then have something terrible happen and then have them come back to us because
Right.
their check was delayed.
Right.
Or,
This month I had 4,
Yeah.
but I've had months where there's 15, 20.
And however, historically, we've had really repeat offenders.
Right, correct.
Regular.
And that's why that
And
addresses.
that's
the
what
repeat.
triggers this.
Right,
So is there a policy for repeat offenders?
that's addressed in here. That talks.
And I read through this, but I don't remember.
We
all of it.
encourage
No,
them
it's
to
So
do
what
it.
is that?
Electronic fund transfer.
So do we have the ability to boot somebody off it if they're like that?
So we have, it outlines in here the fact that if you bounce your checks
Right.
so many times that what your rights get taken away with that you can only pay a cash or money order. If an ECH bounces, again, money order or cash that they have to pay in order to do that. So his office isn't every single month worrying about bounced transfers. And then talking about the fact that they are able to contact a one-time payment agreement that could be done through them with the county with an overdue of no more than 2 months. So if a person did say go into that period and they're unable to pay, and it's the first and only time this has happened for them to contact, we're able to come to some sort of repayment agreement with them. We do understand that there are retirees who potentially we have employees who are in that situation, but they have arrears and they pay it up. But I think like PJ just said, you're talking about people who repeatedly just, can't pay their.
I'm not
their
talking
bill
about
pay.
the person that's running into some hard times. I'm talking about the person that's just using us as their
And then posting all over Facebook when they're on vacation?
Well, I don't know. Well, that should be handled differently to me than.
It's got-
we have.
Yeah, we need a, and after discussions with the county attorney has said, you have to have a policy. When you're dealing with something as serious as, you know, as Brenda had posted about, stated about.
Posted.
If I posted, I didn't know
No, you
about
did
it.
not, I apologize. Had stated about, you know, dealing with potentially someone in hospitalization that you didn't know about, and then that comes or bills or.
So why would you be
prescriptions.
responsible in that situation?
They could potentially, depending on if they didn't know that there was a policy that they were subject to in order to have.
So they're gonna sign off on this policy?
So everyone's gonna have to be supplied. We'll have to decide how we're gonna do that,
They
whether
should
we're
sign
gonna
it.
have them come in or sign it or, you know, or send it certified return receipt. We'll do whatever we need
Are
to
the
do.
letters just, are they sent out certified or anything, or are they just letters sent out?
They're just.
Yeah, yeah,
Right. Until it gets to the point where
The
we're,
last one's gonna be.
that's
Yeah.
certified. Yeah, those are
Yeah.
certified, right.
and it also comes from, the Medicare ones come from Anthem as well.
So do we consider any, I mean, mail has been a real problem of late. Do we consider if somebody's check comes in within the month, they never hit that 30-day delinquent period, right? Because it didn't come in on the first, but it came in on the 7th or the 8th or.
Right, I usually pull the aging on the 10th, send the letters out.
That's why she does the 10th. Yeah.
Yeah, because mail is a real problem now.
Yeah.
And you
certainly
can't, force them to do ACH, correct?
we cannot.
Right, yeah.
But is that more efficient for us?
It's certainly recommended
Sure.
if they can do ACH, absolutely.
Please.
Please do it, but we can't force that. What options do we have to give? Whatever options.
Cash,
Cash
money
or
order,
money.
check or paying ACH.
No credit either, right?
That's up to PJ. He accepts payment.
We don't do credit cards for health insurance.
But we could, if you charge the 4% that would cost us.
Oh.
And you have it,
And
and you
then
have
we'll
it,
advise our
and you
policy.
have it on, and you have it on file, and then it just gets hit every month like everybody else.
Is there any late fees? Because insurance companies do charge late fees and.
Well, it wouldn't be late, because they would hit it every
No,
month.
I'm saying
Yeah, we've
if
never
you're
done
paying manually.
Yeah,
you
we
know.
have not. We've never.
I mean, because honestly, a lot of people rather pay it with that way, and I'm not saying we should change it or not. They get miles, they get points, they
Yeah.
don't have to think about it, you know.
Yeah.
ACH, some people don't like giving their.
I have a lot of people on ACH.
There are quite a few now.
Same thing.
It's just easy, it's easier for them too. But in terms of the Medicare, did we pay the full load or do we pay part of it? Because I only pay, I make the contribution too. I don't make, we pay the full. Okay. So we don't have to coordinate whether or not they paid their part because we're paying the full part. Okay,
Right, but we're not getting reimbursed by some
Right.
people, so we're
Right.
laying out the money. and-
right. No, I understand. I just wondered.
So we're just asking for us to be able to go through, again, as previously through the traditional Board of Supervisors process for us to present this from the Health Insurance
And this
Committee.
policy was reviewed, obviously. by
County Attorney's
County
Office,
Attorney's
yeah,
Office, And this is
everybody. Yep.
standard, basically.
Yes. Yep.
So do we need a motion to adopt it, please? I'll entertain a motion.
I'll make the motion to adopt this, what do we call it?
Second, Rick Square, all in favor? So, carried.
Okay, so next thing, number 4 is New York State mandates. This will be very, very quick. So just to bring, these are no cost inhalers. Okay, just to let you know, this is a January 1st of 2027 mandate. Okay, so this is not something that we have to do now. We just wanted to talk about it. We talked with CDPHP. They're going to be getting us pricing. All right, so that is not something, the way it works now is the first one is free and then they want a replacement to be able to be covered. So we'll get the costs on that. We'll bring that back to you. Okay. Coverage of transvaginal ultrasounds during pregnancy is covered already. So that is something that we will have in our SPD, but just letting you know that these are new things that have come through as New York State mandates. You currently know that any New York State mandate is automatically put into the sheriff's contract. And then the rest of our other contracts are based on approval from this committee. Okay, the transvaginal ultrasounds are already covered under CDPHP, so that is done. And then no patient cost sharing for lung cancer follow-up screening and diagnostic services. Again, that is a January 1st of 2027 mandate. So we're just talking to you about that now. The initial screening is already covered in 2025. There were 26 initial screenings that were conducted. So understanding that of that 26, it's impossible for us to know how many follow-ups they would have. It would certainly depend on what the results of those 26 were. but just to give you an idea of that. So she's gonna, when I say she, I mean Kendra, excuse me. Our representative from CDPHP is going to get some information back to us. We bring mandates to you because we need your support as to whether or not we're putting them in context. So we're done for that. Okay. So premium equivalents for new health insurance tier of individual plus spouse. So currently, as you know, we are in negotiation with 2 of our 4 unions. Our other 2 will be beginning possibly the end of this year. Our corrections and sheriff's benevolent are up January 1st of next year. So as a part of this, what was negotiated was several insurance changes, including the implementation of an additional tier with our E911. Okay, we have an MOA in agreement with E911 for an adjustment to their contract. And what it allows is the establishment of a separation for individual plus one to be individual plus dependent, okay, which we're calling individual plus child because people get confused because when you have a husband or a spouse on your thing, that could be a dependent. So we are going to do child under the Affordable Care Act. So is anyone up to the age of 26? Okay, would be on you as an individual plus child, and then individual plus spouse. Thank you. My gosh, I'm losing my
Is
mind
there
here.
age limit on the spouse?
No, not at all. Let's put it this way. If it's going to be cheaper and they're under the age of 26, we're going to allow you,
Yeah,
number one, good for you. And number 2, we're going to allow you to put that on there. Okay? All right. So
This works in our favor.
it totally does. So just everybody's got this little blurb in front of you. We'll just kind of go through it quick to let you know. In 2024, the county was charged dependent and spouse claims. Allowed means, okay, charged is what's charged by the physicians and the practices. Allowed is what CDPHP based on their contracts allowed. So for individual plus one claims alone, it was $604,000, co-pays of only 23. The county paid $578,000 in 2024. We do not have our final 2025 numbers, so that's why we're using those. So you can clearly see that the cost of an individual plus a spouse is 3 times as much as plus a dependent, plus a child, okay? And that's why we're looking at this. So the 3 scenarios that you have in front of you are potential increases. We certainly did not know where to go with this. So we kind of gave a couple scenarios here. If you think that we should go a different route, we'll be more than happy to run more numbers, whatever you want, and we'll have another meeting and come back. But as of April 1st, the E911 contract states that we are able to separate tiers, and we can have, right now, currently no one in E911 falls under that. They fall under the individual plus dependent, individual plus child. Nah, dependent. Individual plus child, so therefore there would be no increase for them anyway. The first box saying current gives you an idea, okay, of what, and we used management as the example, okay? So understanding that these numbers are going to be different for different unions, but we're just giving you one of our large groups. So currently the premium equivalence under 26 is what we are paying a month for a premium equivalent insurance. There is no individual plus spouse as of declared, so that's why you're not going to see, you see the NA. Enrolled goes to show you, if you go over to current where it says prior to and hired, it's because we are subject to the UPSEU contract, okay? There's no change because it's the current, so there's no difference. This is what we're currently paying. If you go down to upright a picture, good, thank you. So if you go down to the next box, which says scenario 1, what we did was we took based on the 24% increased it to 25. We took the family premium, subtracted out the individual plus one, and then took 25% of the difference. That's where you get the 251.45 over for the individual plus spouse. Okay. And we added that. So Lori went through and did the premiums to give you an idea where if we were to use that methodology, the premium equivalent would go up to $2,770.32. And how we did that, where you see the 251.45, that is what the change in the premium is. If you look at that, that gives the premium equivalent. The $28,000 is how much additional money would be collected in premiums.
So
Okay,
is it from 230, 251 to 251.45? Is that what we're talking about?
so you would be going from so they're currently paying right now $87.53 per paycheck is what an employee that was hired prior to June 13th of 18 would be. If we change to the first example, that individual per paycheck would be paying $104.95 for an increase of $17.42 a paycheck.
Twice a month, right?
That, yes, exactly. Thank you. And if they were a person who was hired after June 13th, instead of paying $232.51, they would be paying $255.72 for a difference of $23.21. Okay?
4682 a month.
Got it.
Right, okay.
All right. The next case scenario, we went back and said, okay, let's take a look and see that if we were increasing, if we lowered the individual plus child by 5%, and we increased the individual plus spouse by 5%. Okay, because 5% was the increase for the most of our insurance increases that we've done.
Mhm.
All right. Now remember, the most important part of this is what you are establishing is where on the table this premium is going to be. Okay, because you have individual plus child. Now you're establishing individual plus spouse before family. Every year, we would still be required to go through all of the tiers and establish the premium equivalents based on the previous year's, their claims.
So I want to go back to what I think
Yep.
was baseline assumption.
Okay?
You took the individual plus dependent,
Mm-hmm.
which we're now calling child.
Yep. Mhm.
But why did you choose to do that at the child rate as opposed to the spouse rate? Why didn't you start with that as the individual plus spouse rate?
Well, right now, the individual plus child, because there is no individual spouse rate. It's
There
the
is-
same
So
thing.
there,
We
okay.
have one. We have individual plus one.
Okay.
That's what we have. And the box in the first one,
But wouldn't in most cases that individual plus one be a spouse?
it is, there's
So you
115
took the
compared to
higher rate
33.
and put it on the lower category because the savings is always with the independent plus child.
Which is why we did the opposite for the third one.
Right, but it doesn't show that difference, that delta as dramatically, because you put the more expensive rate with the less expensive category.
No, you put it
No,
with the
it's
spouse.
with
You
the
put it with the
spouse.
spouse.
She's going to 2007.
Right, well, leave the individual plus child as our individual plus one.
In one of the
Right,
scenarios.
but right now, the individual plus one would be an individual plus a spouse or a child.
Right,
So
we're
you're starting,
leaving that
okay.
for the
as-
individual
as for the
plus child. Right,
But you're leaving with the current rate with the less expensive category. And that's an assumption, and I'm
Right.
just wondering why you started with that assumption.
Because if you're looking, the purpose for raising this is more employee contribution towards a larger expense. So why would you take what you already have and then have less money contributed to a lesser number of
I just
people?
think it's easier to justify an increase on an employee plus spouse. That's why, to me, it's easier to justify that.
And I
Because
appreciate
the
that.
spouse is older and
Yep.
likely to have more medical demands than a child will.
Right,
right, that's what we're doing.
which is what we're doing. So
Yeah,
we're
right.
keeping individual plus child the same.
Same as what we
And
have now.
only increasing, in the second one, we are only increasing. So-
Well, I guess I'm looking at it because the plan that I currently buy for our town.
Yeah.
Has the child and the spouse plans, and the child and spouse, the child plans are about 25% less.
Yep.
Than the spouse plan, so
Yeah.
that's why I just didn't understand why we're taking the more expensive rate and starting and applying it to the child.
Because if we did it that way, we would be contributing even more money.
Okay,
Because you would be
Okay,
taking
I
all of the
understand.
money
I
we're
just wanted to
already
understand why
collecting.
you started.
No, no,
but
that's
now I
okay.
understand. Okay.
We would be taking all of the money that we're currently collecting and putting that against the highest part. And then if, using that methodology, we then would be even lowering our contributions even more.
Okay,
Because you'd be taking the savings. So with that, we tried to say, let's do a case scenario where we do an increase to the family
Right.
and a reduction of the dependent child.
okay.
Okay, so that's what the third
That's your
one, that's the
hybrid.
third
That's
one
your
is,
hybrid.
exactly. So the third one was, and we just took 5%. Okay, because we figured 5%, the county's not putting a considerable amount of money that we're already getting paid is losing. But of equal importance, we're not charging additional employees
Right, but with
more
this
money.
Scenario, the contribution is less, right?
For what,
With the second scenario, those are much.
Second scenario, the contribution is about 10 grand more.
the second scenario, the only people paying more are people who have a spouse.
I know, but
Right.
if you instituted scenario 2.
Yep.
The total income to the county is about 10 grand more. Right?
No, it's $28,000 more. Because you have an increase of a premium of $251.45.
No,
Okay.
the next one, the next scenario.
And then the 2770 is then gonna go up. You're saying this one, yes, 10 grand is the next one.
Yeah.
Right. That's what I'm saying to you. It's
Right.
different. But the third one is allowing for individuals with plus child.
Yeah.
Would be paying less.
Right.
Individual
The top-
with-
the
right,
top
right.
two
Yeah,
classes go
that's the one I
down.
was talking about.
Right.
Right.
Yes, I'm sorry. I apologize.
So in
Well,
scenario one, individual and individual plus child stays the same, correct?
because we don't have an individual plus spouse currently.
Individual.
There's individual plus one. It covers everybody that is a one.
It's in that category.
And
Whether
as a-
it's spouse
and
or-
Well, we have individuals,
Yes.
Yes.
so why aren't we raising that?
Because we're not touching anything with individual or anything with family. All we're doing is increasing through negotiations with one of our unions that we have created an additional tier. So you have either insurance that covers one person, you have insurance that covers the employee plus another person. That other person could be a child.
Right.
And if it's a child, they're paying this. If they're over 26, they're paying this. So what we just have to figure out is what are the individual plus the child and the individual plus the spouse going to pay as a premium equivalent.
But the family went up in scenario.
Family did not go up. Family stayed the
Scenario
same.
one,
Nope, family stayed
Family
the
stays
same.
the same all the way
35,
through.
42, 67 is the
Individual
same
individual
regardless.
stays it throughout, the same all the way.
We're not
just
touching
trying to
families.
incorporate-
Adding a new-
Incorporate
adding a
that
new
new
tier.
class, right?
Right. We're adding-
Which is not uncommon. I mean,
No.
other organizations have had a individual plus child, individual plus spouse.
Right.
Or you said you did, right?
So how many, our union does not, but our town does. But so of our 4 unions, how many of them have that category?
We have one so far that's been negotiated. We are working on the second, which is also pertaining to all of our management.
Right.
But we are eligible to put a resolution through next month, not, what is this, April, May, June, because county government has not happened yet, so I could go through. I'll probably go into county government this month to look for management and NBU to be increased to what this is as well. We need the premium equivalent to be established before we can introduce the
and to
increase.
give everybody a percentage increase would be what?
Management and NBU would any individual plus one would be changed to this as well.
What I'm saying is equal amounts across the board.
Well, not.
No,
not
It's
family or not
establishing
individual.
Right, it's just establishing the premium equivalent. And then from the premium equivalent, then it's the negotiated rate as to what each union is subject to paying. This example is one of our unions that happens to management is subject to it. So that's why you have the two individuals that were hired prior to June 13th of 2018 are subject to a certain rate. Those hired after that same date they get something different. We didn't want to give you, literally, you would have 82 examples for all the unions that we have and all their payment stuff. So we're just trying to make it easier for you to look. So using scenario 2 as an example of a 5% reduction, you're looking at the same premium equivalents for an individual and for family. We took the individual plus child, all right, with the 33 people that are currently enrolled in that program. A 5% savings to them would be $125.94 less a month, which, as PJ said, times that would give, they would be paying $4,100 less a year if you were in that category. The individuals plus
That's
spouse,
fair.
the individual
I
plus
think that's
spouse, right, and
fair.
that's why we weren't looking to try
I
to
know, I
make a
just wanted to
25%
understand how you
increase.
got
No,
there.
I
I wasn't
appreciate it.
questioning, I just want to understand how you got
I mean,
there.
And then-
it's fair, but I don't know. We still have no money, we still have a reserve of no money, so I don't know why we would reduce anybody's.
That's where I'm at. I don't understand why we're doing.
And that's not, that's what, yeah, no, I understand.
But that's only looking at a proposed 5%.
I think
Right.
it's because you want that rate chart to be proportional. When you're going through and explaining to people what their contribution is, you want it to be. And obviously you are gonna make less demands in your insurance I understand there are kids with diabetes and kids with mental health issues, but for the most part, our experience with healthy kids is they use a lot less.
Right, but you're one group you're hitting and one group you're reducing. It seems to me
Well, because we have an opportunity to address.
why
any-
can't you leave it flat and then do the other one?
Because I don't know of a single plan where individual and spouse and individual and child are the same. There
That's what
is.
Yeah, I think, but
there's
you
no
would
plan.
leave the individual and child as it is now, but bump up the spouse one by 5%, whatever.
Right, that's what I'm saying.
Well, that's an alternative, right?
That's
We could do
exactly
that.
what I'm saying.
Of course we can.
I mean, to not go up in today's world is a win.
Yeah, right, yeah. Okay, so just to be clear with the table that we have here, what you're suggesting is kind of a nice hybrid between 1 and 2, where you're looking at individual would stay the same. The scenario of the 33 individuals with individual plus child would stay the same premium they're currently paying.
Yep.
Okay, and then the individual plus spouse, we could go up only 5%, and that would be down on the bottom where we're looking at an increase of the 124, the 125.
And you're saving 18,600.
Right,
18,700.
so
I just think that, I just don't know that that will bear examination because those gaps are so much. I mean, if I look at my MVP plans, I'm paying, I think 1,300. I'll send you the numbers
Mhm.
for an individual plus child, but an
Okay.
individual plus spouse, I'm paying 1,800. So that's almost it's a 40% difference. It's not a 5% difference.
right.
I think that's really hard to justify as a 5% difference. So I don't know how we get where we want to go, but I'm just saying, if people are looking at competing plans, like a union plan.
Yep.
We need to understand that.
But understanding that the individual plus child premium is going to be 20, at that point then would be 25,1887. And the individual plus spouse would be 26,4481. So if you're looking at individual is still at 1254.55,
Right.
1254.44. Which then we would keep our individual plus child at the 25,1887 and increase it to spouse to the 26,4481.
For 5%.
For that, that's a 5%
And that's what
increase.
I'm questioning. I'm
Mhm.
just saying that
Right,
5%, I don't think is gonna bear, it's gonna come out. I mean, I don't know that people have a choice because this is a group decision, not an
Right.
individual decision. But in most cases, that gap is much greater. That delta is much
Mhm.
greater.
Right.
We can raise the individual spouse by 20%.
We could also just gradually get there, because if you do the 25%, that's like $600 a year to these, to someone.
And I think that's steep. I
So
agree
maybe
with
we
you.
use the 5% now, and then when we do the premium equivalents for 27, we maybe do a little.
Does that have to be
more.
negotiated though?
I was gonna say, how
No.
long is this in effect for?
So premium equivalents are reevaluated and established by the Columbia County Board of Supervisors every single year.
Right.
They are not negotiated. Our unions are invited. They come in just so they know ahead of time what we're doing. And this committee establishes them based on the prior year of.
So when we look at these rates, what are we looking to implement
So
that?
all you're doing at this point is establishing for a new tier, where is it going to fall?
Just for the new
in
tier.
Right, the new tier. That's why we're not looking at individual.
Okay.
We're not looking at family. Those are the rates that were approved by this
Gotcha.
committee in October or November of last year.
Yep.
So this will all be looked at again
Mhm.
when we come back in late fall.
Got it.
And then we'll look at what our actual claims were.
Yeah.
So, and then every one of these tiers are gonna change. Yeah, we're just establishing the percentage difference between
Got it.
an employee, individual, excuse me, plus a child and an individual plus a spouse.
What is the normal percentage difference? Is there a
There
percentage?
isn't.
They're all so big.
Yeah, no, I mean, it's,
But mine is like a $500 difference between
Yeah.
1,400 and 1,900. That's why I'm saying it's,
Well, but, okay, yeah, I was gonna say, because there's not a much difference now.
that's a monthly premium though.
You
It's,
know, without even raising it, there's not much difference.
well, that's the difficulty, I think, in folding this new one in. Is how do we perceive it? And that's why I asked why they started with the existing number with the higher tier instead of the lower tier, because the lower cost, right? But I understand your point about, we don't have anything in the reserve and maybe that's where we should start is put that with the child, but then, I don't know how to get to where we need to
and I
go.
don't think there was any motivation from anyone to drive the individual plus spouse up to an unaffordable, it's not the intent to bring that up to the family premium. Because the family premium could be 3 people, but the family premium could also be 9 people. It's impossible to know that. So that's why it's kind of, you don't necessarily, it's not just always 3 people that you're looking at. Oh, you're going from 2 to 3, so you can't just have it just underneath it.
But we are looking at, almost 4 times as many people in the individual plus spouse
Yep.
category as the
Yep.
individual plus.
Which is
child.
why you would have that additional 14,483, absolutely, based on the current 115
I
enrollees.
mean, it's a starting point. I mean, I think if you
All subject to conversation,
Yeah.
exactly.
So
Well, it seems like
So we
it's
did a
good.
motion.
my town, I just looked up our chart. Child, employee plus spouse is $230 a month more. So it's 1530, and then employee child is 1300.
I want your plan.
Yeah, right.
You better talk.
No, but I'm sure our difference is more than that, but I think, you know,
Yeah, but that's like $100 less than what we're doing here. It's not that much.
Whoever
Based
said,
on Matt's, it would be $27.50.
So you're looking at an employee prior to June 13th, their paycheck going up $8.72 a paycheck versus hired afterwards be $11.63. And again, this can be looked at when we look at premium equivalents.
Right,
So
so
I-
all we're looking for now is a motion to establish. what-
That we're gonna keep
For our-
individual and child the same and raise the
That's not
individual
even
spouse by 5.
No,
No,
that's,
no,
that's
That's not
just
even a
adopting.
conversation.
No, no.
We're adopting the tier of
Okay.
individual
That's
plus
it, no
spouse.
figures.
Right.
Yeah, we would be we're gonna put in a resolution to the Board of Supervisors to adopt a tier of individual plus spouse and to establish the premium equivalents for 2026 effective 4/1/26 to be, we're gonna keep individual plus spouse at the current individual plus one rate and then establish the new individual plus spouse.
no, we're gonna.
Plus child.
Plus child,
Right.
plus child is the, yes,
Right.
sorry.
Actually, we're gonna
Oh my
keep the
God.
rate for the individual plus child.
That's what I meant.
Right.
Do we have a
We had
motion based on what you
I'll
said?
do
That's what I
that.
meant.
Now you- I think I know what we're gonna do. Take my resolution for me, please, I love you.
I'll second.
Second.
I'll second.
Rob, we're going to second. Discussion? All in favor?
Aye.
Opposed? Carried.
But then when it comes out to
We
negotiate.
don't pay you enough money to do
It's already
this.
done in that.
Right, but that one, yeah, but-
I'd rather have all, sheets I have pulled out than have to do this.
Oh, they
We
just.
established it. We established it. So. Okay, so the last piece is the last piece, because we're done, right? We're till 3 o'clock? Yeah. Okay, so we don't need to do the last piece. If they hadn't wanted an update on negotiations, I would provide it.
I
If
would love
not,
to have an update, because I'm not on the negotiations committee to get time to do that.
We've got, you want an executive?
yeah, that's why I put executive, yeah, because I feel for negotiations, we have to.
Do you have time?
I'm sorry, yeah, we have to. Oh, okay.
Executive.
Sorry about people kicking you out.
If you want to go into executive session.
We're talking 5 minutes. Max.
I need a motion to go into executive session for the purposes of,
I'll make that motion.
Second.
all in favor?
Aye.
Nice.
It's what, contractual?
Yes. Stop this first, and I'll put this in the door.
Gary?
Did you say, Matthew, that was the difference between 1,300 and 1,500?
Possibly.
$230.
Okay, so that's a 15% difference. And I think mine's 20. So
Mine's-
that gives us an idea of where we need
Is
to
there
be.
any other business? If not, I'll entertain a motion to adjourn.
So moved.
Second,
Second.
all in favor?
Aye.
Opposed?